Okay, I'll start with this one. Here is a radiograph that shows findings typical of granulomatous disease in the form of calcified pulmonary granuloma, as well as calcifications in small regional hilar and perihilar lymph nodes. So very typical as a consequence of that. I don't have a radiograph prior to the CT, but this is what the frontal projection would show. There is opacity here, some subtle findings of volume loss located in that left upper lobe. And here I'll bring alongside some images to show you the location of the calcifications and the presence of opacity consistent with atelectatic lung in the left upper lobe. And then again, look at the relationship between these calcifications and airways, particularly this bronchus in the left upper lobe. Let's see if I have thinner cuts for you. Nope, that's a MIPS image. There we go. At another time, there is less opacity of atelectasis, but you can see post-obstructive phenomenon in the form of dilated bronchi in the anterior segment particularly, some of which contain some intraluminal material. And then again, the close relationship between particularly these calcifications and the upper lobe right there. So here are images. I hope they are here to show you the findings on bronchoscopy. As you might suspect, we have compromise of the lumen, and this shows a calcified lesion on bronchoscopy. So we have those calcifications that have, over time, at least in part, made their way into the bronchial lumen, producing obstructive atelectasis. The patient had a lobectomy. We have necrotizing granulomatous inflammation, calcifications, GMS stain, some fungal hyphal forms within a granuloma, which is interesting. And again, nice findings on bronchoscopy that go along with that right there.
Howard, did they expand on what type of fungal?
No, it seems like I've somehow, no.
Presumably histo or cocci or something.
It just is, no, I don't know. Within a granuloma.
Does histoplasmosis ever have a filamentous form, or is it just a yeasty looking thing?
It's usually a yeast in the body when it gets to human temperature, and that's what makes it pathogenic and non-contagious. But maybe, I don't know what happens when it gets trapped in a lymph node.
Yeah. Okay. This is a really interesting case. I've just a little while ago actually got to look at some images from the prior hospitalization. So the images that I got to see that I couldn't make head or tail of were these. So here is the frontal projection of the chest showing multifocal, multilobar disease. It's hard to describe these opacities other than being just relatively large, nodular, ill-defined, very coarse reticular opacities throughout the lungs. And here is what they look like on CT. So we have a lot of interesting findings. In some locations, we have some cystic disease, which I think may have an explanation, and I'll mention that in a moment. Now, some of them, of course, are subpleural. That could be just paraseptal emphysema, but not all of them were entirely subpleural. Then we see there's a lot of nodular disease. Some of the opacities get larger, and you can see the locations of them, particularly large here. There's some areas here, like right here, in which there's apparent cavitation or cystic disease. And then another notable feature here is that in relation to many of the opacities, the airways that traverse them are still patent, which is relevant to the diagnosis. And then we can see here that there's a lot of disease, that there's a close relationship to interlobar fissures. Some of the opacities are subpleural. When we see that, we think of sarcoidosis just by location. And then I'll just bring this up and I'll mag up here to show you what I also discern, which is that there's a lot of airway-centric disease. So about the bronchovascular bundles and about these bronchi, there's a lot of disease. Sometimes the lumen is narrowed. So in terms of location, there is a lot of peribronchovascular disease. And in some locations, the airways may be opacified, occluded, and there may be accumulation of secretions within the lumens. But that's a striking finding, how extensive the disease is, how airway-centric it is in the lungs. So now I'll show you images that I got later on, just to show you that this has been going on for a long time. So this goes back to July of 2019, and I'll just briefly swing this around. This image is somewhat degraded by motion in many areas, but you can see the disease is pretty much the same as it was before, just more extensive in the lungs. And then I got one too from June of last year, and the lung biopsy was done the following month to show you the findings are very similar to what we have now. So the disease is persistent, of course, maybe mildly progressive over a period of time. There is some modest lymph node enlargement in the mediastinum, the hilar regions involving some intrapulmonary lymph nodes, but of course that's not the dominant finding. So this is a case under a surgical lung biopsy from a surgical lung biopsy of IgG4-related sclerosing disease. And I've really highlighted in red here the very classic findings under the microscope, which is a form of fibrosis that is called a storiform fibrosis. That's very typical, and the presence of an obliterative phlebitis. Those are the two classic findings in pulmonary IgG4. I think other places too, of course. And then lots of IgG4 positive plasma cells. So a really interesting case. This is the most florid that I've seen for sure of this entity. And I speculate that maybe some of those plasma cells deposited immunoglobulin-associated light chains, accounting for some of the cystic change, perhaps. But otherwise, a very interesting case of that entity. And it's described as one kind of presentation one may have, but this is certainly pretty florid. I've seen very few cases involve the lung, and usually they just produce opacities that are circumscribed and relatively limited in extent when it involves the lungs. Anyone seen a case this florid?
No, this is.
Very interesting, huh?
Yeah, and you know, if you didn't have the other things you'd have to think about would be like adenocarcinoma or something. It's so like some of these nodules look bubbly because they're around airways. It's crazy.
Yeah.
That's what I was going with, was an adenocarcinoma. At first, I wondered whether you were going to show us a case of amyloid because of nodules and cysts. that were predominant in the bases. But there was no high attenuation stuff. You never showed us the soft tissue window, but I don't think there was any attenuation. And then the progression here, I thought this was an adenocarcinoma.
It was a little bit, well, from 2019, that's a long time right there. Yeah.
Amazing.
Yeah, very interesting.
So
So the actual context of this was curious, because when I read the radiograph and saw that, it was a workup for the patient who has chronic renal failure. So he's got a porcine glomerulonephritis, and it's almost like pre-op imaging, although I can't explain the CT. And I just couldn't put the two together at all. And I thought, this is really weird. And I was definitely perplexed. I wouldn't have thought of that diagnosis. Although it makes sense, at least now that we know the diagnosis, and thinking of the distribution of disease when one has lymphoproliferative disorders that are extensive in the lungs, particularly related to airway-related lymphoid disease, perhaps.
But also the lymphadenopathy in the mediastinum is also good for it too. Sometimes it resembles sarcoid.
Yeah. Okay, we'll look for another one like that, but I'm not sure I'm going to ever see one again. Let me show you this one. I know David's going to like this one. So we've shown this before, but unless I'm mistaken, there's some findings here that are really interesting. So I'm going to show you. I'll get the right button. Calcifications, 2 of them in the basal hemithoraces. Now I'm going to change over to that window, and I'm going to make this a little bit less noisy, just a bit, to show you these. And appreciate that these calcifications are surrounded by tissue, so that one there has some tissue around it. So it's an item that has a central calcification. And even this one has got some tissue around it. Now I try to measure really carefully here, because I was wondering whether the attenuation of the tissue around it was kind of fatty, but it's really hard to say. There may be a little bit fat there and a little bit there, but each one seems to be embedded or surrounded by some tissue. So this is a previous CT of the spine. The time between these two is that. And you will see that with respect to the one on the right side, it used to live, I know I went by it somewhere, right there. And the one on the left side was a little bit more lateral. So these are great cases of migratory thoracoliths. And my speculation is that, well, the idea I believe is that these represent areas of calcific necrosis that occur in extrapleural fat, and then they break off into the pleural space. So it makes sense that they carry a little bit of fat or infarcted fat or something with them, right? And I'm not sure if I've seen that before. I've seen the calcifications before, but does everyone agree that there's a little bit of tissue that surrounds them? Presumably,
Absolutely.
a little tissue that was carried with them?
Yeah, and the thought about the extrapleural fat necrosis, I saw a presentation at a conference about this where, when you get a pneumothorax, sometimes you see some fat blobs sort of dangle. They're extrapleural, and the person who presented it, they had a case series. It was several years ago, but that was their theory, that when they either torse or infarct or whatever, necrose, and then undergo dystrophic calcification, and like you said, they sort of migrate into the pleural space, which I find interesting that they would migrate into the pleural space, but I guess it's only a thin layer of cells. So
yeah,
those are the biggest ones I've ever seen.
Aren't they nice?
It's kind of like an inverted donut here with a dense, and I'm not sure that's really fat though around it. I just, I wonder also whether they acquire a little bit of pleural fluid, some protein settles out on the calcification, and it's just sort of coated with pleural fluid that's kind of dried out or something like that.
Yeah, who knows?
Yeah,
It's not pure fat, but it's of some low attenuation in some areas.
it does
But if
look.
it's fat, it could be kind of infarcted fat or got some
Yeah.
fibrosis in, if that's what it is. But it's a plausible theory, and this lends some support to the notion that that's where they start and they come off there and that's where they end up.
I think the only problem with that theory is what Jeff raised, and that is how do you've got to get across the extrapleural, the parietal pleura to get into the pleural space, and it's not obvious that you could do that. So,
Right.
but it's plausible, I guess.
Yeah. Okay, Jeff, I'll save my others for the time being. Did some other folks show?
Jeff, I have a couple this week.
Great. I'll be ready in a little bit. Let me go ahead and make you presenter.
Can people see a scout view?
Good.
Okay, so this woman has a mediastinal mass at this level here, just slightly above the aortic arch, and she has some left pleural process. I think this was a recent phenomenon. This mass has been growing for a few years, and it has some interesting enhancement to it. So this sort of snake-like central enhancement, some enhancement along the edges. Not very impressive vessels feeding it. You think of a vascular lesion, maybe these are vascular things lighting up. It did light up with the contrast, so this is some sort of enhancement going on. So we think about it, maybe a paraganglioma or something like that. So any other ideas about what this might be?
It's where the phrenic nerve lives, so one should at least think about a schwannoma, although the ones most of us have shown are more uniformly attenuating rather than this one that seems to have low attenuation within. But I would still put schwannoma in the differential by virtue of location.
And then there's a little question about, is there could this be a malignancy that's actually extending into brachiocephalic vein?
Wondering if that's on top of it or in it.
Yeah.
Kind of looks.
Or maybe this is some inflow from someplace, and
And you said it's been slowly growing?
Slowly growing over, I think I've got 3 years on it.
Slow growth.
Some kind of like sympathetic tumor.
Okay. Well, this was biopsied, and it is a capillary hemangioma. So it's a sort of pretty rare mediastinal tumor. They're supposed to be benign, and therefore this finding of the suggestion that something might be growing into this vein is a little bit concerning. But capillary hemangioma is the working diagnosis. Now there's going to be a definitive resection next month. So if things change on that, when we get the whole sample, I'll let you know. But capillary hemangioma. So I don't think I've seen any hemangiomas myself, but I think you guys have shown some in the past. So it does exist. And I remember Tan Mohammed sent a case years ago of a hemangioma in the mediastinum. There are certain conditions where there are lots of hemangiomas in the body. This person is said to have hemangiomas in bones. So, I was looking up the hemangioma syndromes and stuff like that, and nothing really fits very well. And I don't have any imaging to show bone lesions in this person. So right now, that's just kind of a rumor.
So David, it's interesting because I typically, this one doesn't have, I didn't see phlebolus in it, but could it be that venous involvement is actually it's one of these slow flow vascular malformations, and it's draining into that brachiocephalic vein?
Yeah, I was wondering about that too. And I don't know what, when I read about that, the idea is if it's a vascular malformation, you're supposed to have a normal looking endothelium. And if it is a hemangioma, then you're supposed to have fat cells that are the endothelial cells. So maybe when we get the whole specimen, they'll be able to make a better assessment of that. But that's what I wonder too, because you guys have shown some of those malformations and stuff like that. And, you know, I think that would fit with this finding as well. You know, the finding might be something in the vein there.
But at the same time, I think it was Travis showed years ago a case of a spine hemangiomas in the bone that actually extended out of the bone and into the, I think, into the canal. So I guess they can take over. But
right.
Yeah, the invasive vertebral hemangioma.
Yes.
Has anybody seen a mediastinal lesion like this, though?
No.
Not without phleboliths.
Yeah. Okay. Well, if anything changes next month, I will give you an update.
Yeah, please do.
Very interesting.
Okay. And speaking of mediastina, here's a person who is a bone marrow transplant candidate. I think had a double cord transplant. And this is the radiograph in December the 2nd. And later in December, in the 20s, just after Christmas, the mediastinum also was nice and svelte, looked good, a little bit of basal atelectasis here, lowish volume. And then the mediastinum rapidly puffed up. So now we have this convexity on both sides of the mediastinum, and on lateral view, you can see we have this anterior mediastinal mass that has just come up out of the blue. So in just a few days, this thing popped up quite large. And this person is being treated for leukemia. And here's what CT looks like on this.
That's a few days?
Just a few days, right. So between, you know, I'm showing you an early December image because it's comparable with PA and lateral, but late in December, the mediastinum was also normal. So say, let's say from the 28th of December to the 5th of January, just about a week, the mediastinum has puffed up. And there's been no catheter manipulation or anything like that to cause a hematoma. The catheter was already there, placed in November, so months ago. And we have this anterior lesion here with about 23 Hounsfield units of attenuation. It's very uniform. And it's outside the pericardium. There's pericardium. This is all anterior to pericardium, so it's not part of the pericardium. There's a little bit of stranding in the fat here. So, you know, maybe a little stranding down there. And that's it. So, you know, we were thinking about all sorts of exotic things. Could this be some sort of PTLD released by the transplant regimen? Could this be something EBV virus associated? Could it be Castleman's? Could it be HHV8 disease of some kind? And all that sort of stuff. So they needled it.
The attenuation I know is not high, David, but does it have ill-defined margins so that a hematoma is still a consideration?
Well, you know, I think there's a little fuzz in the mediastinum around it, but I think the margins are pretty sharp. Doesn't really look, I don't know, what do you think? It doesn't really look that infiltrative to me.
When you go higher up, it seems to be sort of, let's say, soft and infiltrating the fat a bit, like there, yeah.
We do have some fat stranding, as mentioned before, so it's, you know, could be something inflammatory. So any other considerations, guys? This was a real head scratcher.
Any chance this was some sort of rebound thymic hyperplasia?
Yeah, that was my best guess.
Would be the biggest in the world ever recorded.
I'm sorry?
That's too big.
Yeah, that was I thought the most plausible thing, that with this transplant regimen and stuff like that, they set the thymus off, and so they biopsied it and they got epithelial thymic cells, and decided that it was a lining and stuff like that, and they called this a thymic cyst. So I've never heard of acute thymic cyst before.
No.
Well,
But it
maybe
was
there was a small thymic cyst lined with thymic cells, and there was a rebound hyperplasia that made the cyst get acutely bigger.
Yeah, but there wasn't. I had an earlier CT which I've not shown you this morning, but which I downloaded that showed absolutely no thymic tissue, just a couple little dots in a small amount of fat in the anterior mediastinum. So nothing that really looked like a precursor cyst or even much thymic tissue at all, just a couple little dots of tissue, the way an involuted thymus usually looks.
Right.
But I wonder if you could set off the thymus in a way that would cause it to produce a lot of fluid for, those thymic cells there's a kind of thymic hyperplasia that was very effusogenic or something like that. I mean, really having to scratch my head here to come up with something plausible.
Yeah.
And that's a needle biopsy, David?
It's a needle biopsy, and on a later radiograph about a week or so after this, things seem to be shrinking down a little bit, but we don't have imaging more than a couple of days after this CT scan. So I think the last imaging was on the 7th of January. So it's not symptomatic, and it was a little bit better on that later image, which I've not shown.
That's really cool.
Have you? I've never heard of acute thymic cyst. That's not an entity.
Wow.
Okay. Okay, guys. So those are my mediastinal issues of the week. I want to thank Karen Ordovas for providing that hemangioma, capillary hemangioma case, at least putative capillary hemangioma so far.
That's cool. Well, let us know what the final path is.
Okay.
And follow up on this one, because I've never seen a rebound thymic hyperplasia this exuberant, if that's what it is.
All right, let's see. I know Travis doesn't have anything this week. Peter?
I got two, Jeff.
All right, perfect.
Be quick. Both of mine are cardiac from yesterday. They're pretty interesting. Well, this one is just a good example. So this is a 56-year-old lady, and I'll just show her MR here. Just selected a few images. This is a 3-chamber, kind of concentric hypertrophy, unchanged for many years. 4-chamber, same thing. Back to the 3-chamber. She has what we call systolic anterior motion. She has chordal, systolic anterior chordal motion here of the mitral chordae with some narrowing of the LVOT. So this is something you typically see with hypertrophic cardiomyopathy. This patient actually has another disease that looks the same, Fabry's disease. Which is one of the glycolipid storage, lysosomal glycolipid storage disorders, X-linked. So she's in her mid-50s. She was diagnosed at age 18, and she has kind of the typical cardiac manifestations. The other interesting thing on her cardiac scan is on the delayed enhancement. But this is kind of the classic finding on the day of late gadolinium enhancement. And it's usually mid-myocardial, but one of the more typical places that's described in the literature is lateral basal wall, which he had. And probably the most specific cardiac MRI finding, sensitive and specific, is the T1 mapping, low values of T1 mapping in the myocardium due to deposition of these glycolipids. So this was also a finding we had. So she had low T1, and basically otherwise looks very similar to hypertrophic cardiomyopathy. She's on enzyme replacement therapy and has some of the other systemic manifestations of Fabry. So just good example. Apparently, one thing I read is that these the imaging findings are so similar to hypertrophic cardiomyopathy that 5% of cases that are called hook 'em on MR are actually Fabry's.
Does anyone understand the pathogenesis of that motion of the anterior leaflet? How that comes about? Is there something about structure of the heart and the hypertrophied myocardium or something, or the tendony?
Yeah,
involved?
I'm getting the eponym, maybe Jeff or one of you guys will, but it's basically just velocity. There's just it's just the relationship between velocity and it causes like a suction up. The Bernoulli effect, I guess, is
One
my
of those Venturi or something like that?
exactly. It causes a decrease in pressure, and then
So the narrowing of the outflow tract comes first, and the systolic motion of the
and I'm not sure if that's I think that's one of the theories. I don't know if they have it completely explained. I think there's some controversy as to exactly why that happens, but I'm not completely sure.
Very interesting.
But yeah, that's typical for hypertrophic cardiomyopathy finding. The other one is interesting, is a coronary CTA, 50-year-old patient, no calcium score, so 0 calcium. And one of the interesting things on this patient, this is we read for a hospital. We have a contract with the remote hospital, and they send us their studies sometimes, and we read them. So we don't have a lot of history for some of these patients, but they send the paperwork with their vital signs before the scan, and I noticed this patient had the initial blood pressure was 120 before the beta blockers were given, and then right at this time of the scan, the blood pressure fell to systolic fell to 60, and then he became very bradycardic into the 50s. And so here's his coronary scan. And so everything looks nice except the right there. So the whole, you can see the whole LAD here. There's some bridging, so the LAD goes, this is a vein, that's not the actual LAD, the LAD is in there. There's some bridging in it, and it'll pop up right there, but it's completely occluded. So this was a completely occluded, acutely occluded LAD. And the patient was rushed to the cath lab and got stented. It actually did pretty well. So I'm not sure when this happened, if it happened right before the scan or what exactly, but it's kind of a strange case because it's a patient in their 50s and without any calcium, and just developed this. You can kind of appreciate here, we see chronically occluded vessels, and but you can see how like this almost looks dilated here, right where the stenosis is, as you can see it on the. So with the chronically occluded vessels, they're very small over time. They just become more diminutive.
Is there anything about the morphology such that spontaneous dissection with occlusion of the lumen is not a thought?
Yeah, that was a thought, but yeah, that was one thing I thought about. But I usually from where I've seen 1 or 2 examples of that hasn't been a complete occlusion like that. I don't know if that's those. And then the other thing is that you did well with the stent. So my thought was that this was just a proximal plaque rupture and just complete thrombus, and then distally there's no time to have collateral, so there's no development of flow, because usually we see a chronic lesion distally, there's some flow after the.
I guess it might be embolic. I mean, I'm seeing a little convexity of the edge at the filling defect.
Yeah, I don't know, we have no history, so.
And there was no echo evidence of atrial septal defect or PFO or anything like that.
Don't know. We don't have any any, we only get the images and then so I don't know.
ECG tracing?
What's that?
You get the ECG tracing even just for the gating?
No, and then
No.
I texted the I texted today the cardiologist we read for. He just gave me some follow up about the stent, but that's all I know.
Okay. I wonder if, like,
Yeah.
'cause sometimes for the gating sequence, just if there was any like T wave elevation.
Yeah, that would have been interesting to see.
Yeah. Well, that's impressive. Well, I guess the calcium score 0 isn't perfect.
Yeah.
So that if someone images a patient with acute chest pain, is a non-contrast series to look for calcium part of the protocol in some places? Because that's curious about the whole case is curious, isn't it?
Right, probably not. And I don't know exactly how the events transpired.
Okay.
So at this hospital, what day, but by the time I got the scan and read it, I'm assuming, I think somebody had already taken a look and prelimed it and had rushed the patient to the,
Yeah.
so.
Peter, on your contrast study, can you just check for continuity between right atrium and left atrium?
Yeah, sure. Yeah, I don't think there's a ASD there.
Okay.
I don't see any mixing. There is some interesting mixing of the, but I think we see that relatively common in the pulmonary veins of contrast.
Yeah, a little smoke artifact.
I was looking at the lungs. I think it's a lung problem. Let me just get rid of this. Yeah. There's some minor, I think, small airway disease.
And there wasn't a filling defect in the left atrial appendage there, was there?
No.
On a darker window, it looked to me as if there was maybe.
No, I think it was just mixing, because you see the amount of mixing in the veins. It just seems kind of low.
And no mitral vegetations or anything.
No.
It's very strange.
Yeah.
Yeah.
Thanks for sharing.
Thank you.
All right, let's see here. So I'm curious what you guys think about this case. So this is a 70-year-old. This is a year ago, and you can see it looks pretty normal. The patient got COVID back in, I want to say, November-ish. I don't have any imaging, but this was their radiograph in December. And you can see there's sort of a hazy opacity in the right lung here, maybe some reticular stuff, nothing really on the left. So this is December, and here we are.
The patient didn't be hospitalized, Jeff, just had a diagnosis.
Just had a diagnosis of COVID.
Okay.
Yeah, as far as I could tell. Here's the patient more recently, and you can see that there is more distinct reticulation. It looks pretty dense down in there, and it seems to be, again, very much confined to the right lung. The left lung looks pretty good. So they did a CT scan because the patient's short of breath, and has just recently had a thyroidectomy, so that's what that's about. So unrelated. But there's a little bit of residual, or there is not, I don't say residual, but there's some ground glass opacity. It looks like a little bit of organizing pneumonia, very subtle in both lungs. But the reason I'm showing this is you'll see there's some mild fibrosis, but it's really dense looking. And I'm going to change the window here. And you can see that it looks more like dendriform ossification or something like that, some calcific material there in that fibrosis that developed over the course of a year and looks like it really sort of has progressed over the last month or so. Because, I mean, it may be technical, but the intermediate radiograph was less convincing for the dense stuff. And it's really confined to the right. So I presume there's some subacute lung injury from COVID. There may be a little bit of fibrosis, but have any of you ever seen pulmonary ossification develop rather this quickly? I mean, I suppose he could be aspirating, but I couldn't find anything pointing to that. And the fact is even if he'd acutely aspirated recently, I wouldn't think you'd get pulmonary ossification that quickly. and no hospitalization, just except he's post-op from his thyroidectomy, and was normal a year ago.
So Jeff, did he have renal failure as part of his syndrome?
Good point. And well, he's got polycystic kidneys, so I don't know how much. He's got some kind of renal compromise. You can see, I mean, it's a little noisy. Let me just thicken this up a bit. I'm sorry? He's CKD 3, so yes, some not end stage, but definitely has some renal insufficiency. So you think it could just be dystrophic calcification in the setting of chronic kidney disease?
Well, I've seen DPO come up in a couple of months, so it can come up fast. But if in the setting of renal failure, you have to wonder if there's a dystrophic,
Right.
component with the acceleration of calcium deposition because of the abnormal calcium product.
Okay.
But it's so punctate, it really looks more DPO-ish. And I have seen DPO come up in a couple of months after
Okay.
somebody had pneumonia or aspiration.
Yeah, well, he had COVID, so I'm presuming it's from that.
Yeah.
And he still has a little bit of residual. He's got a little bit on the other side, but clearly there's an asymmetry. But I just thought even the radiographs, this was baseline. This was mid-December, and he clearly has an abnormality out there, maybe a little bit of stuff out here. And then this is contemporaneous with the CT scan. And there's a little bit of image enhancement, but I think it's still denser than it was before. Well, that would explain a lot more then. Okay, that makes sense to me. I still figured it was all from COVID because I didn't have a better explanation, but I just hadn't seen, I've seen some residual fibrosis, but I've never seen DPO, but that makes sense that it was that quickly. Okay.
So David, you've seen DPO form in a focal abnormality like a resolving community-acquired pneumonia or some other pneumonia.
Yes.
And the calcium's formed just in the area of the lung that was involved, but very focal.
Yes.
Wow, I wonder if I don't recall seeing that. I may have missed it, but that's interesting.
Okay.
So Jeff,
Yes.
on the subject, for us thoracic imagers here, I think we've been missing a bit on these long haulers after COVID. There was an article on PBS News last week, I think, at the end of last week, or maybe the beginning of this week. They had a Chinese scientist who I think was a physiologist, not an MD, who showed he took CT information on people who were symptomatic shortness of breath, had shortness of breath after COVID, sometimes long haulers, months out. And he showed this profound vascular abnormalities on people whose CT interpretations were called normal. So he's somehow processing the images to bring out either vascular narrowings or hypoperfusion, because he showed these vessels with different colors. And the people who were symptomatic had all of these dark blue or black vessels, and they were sort of irregular and stuff like that. So I think if we look more carefully at blood vessels, we might see why some people are so hypoxemic and continue to have symptoms after COVID. So he showed one person with normal at the beginning, and then a long hauler with modest abnormalities on this vascular imaging, and then he showed the same person when he was acutely ill, and he had a lot more vascular abnormalities. So there was some reparation, some healing, but there was still a noticeable abnormality. So I don't know what his technique was, and they didn't let on. But if you guys are doing any exotic vascular imaging, it might be very useful in this setting.
Yeah, I mean, we're not CTing them typically unless they, we do a non-con if they, we haven't had a lot of them that are still, the ones I've seen typically have residual organizing pneumonia that just hasn't cleared all the way, but I haven't seen any that look normal. I mean, I don't know. It may be interesting. I guess you could do a dual energy CT or a traditional perfusion scan, or even an MR angio with looking at perfusion.
I think SPECT imaging might work well.
Yeah.
With that. Yeah, and a VQ scan would probably maybe reveal some of the same things. We had a patient earlier this week that had a lot of mosaic attenuation and some air trapping on expiration, and this is post-COVID with shortness of breath. It struck me, though, that the mosaic attenuation was more extensive than the air trapping demonstrated on expiration. So it's possible that there was both a vascular and the airways cause of the mosaic attenuation.
Yeah. That'd be interesting. Yeah, I think this long hauler phenomenon is probably a broad category because there was a story on NPR about it, but a lot of those patients, it's more just fatigue and sort of forgetfulness. Well, I guess hypoxia could contribute to that, but it's
But also,
more systemic. But you wonder if there. I mean, we clearly are going to see. I mean, patients with ARDS who recover from other causes often have at least some kind of deficits in their lungs, I guess. But if COVID's sort of a double whammy hitting the vasculature and the airways, you can imagine why they're still short of breath walking upstairs and stuff.
they also have an autonomic dysfunction where
Yeah.
they get this tachycardia with minimal exercise. There's a name for that.
We'll have to keep our eyes out for that. Okay, well, David, this case is for you. This is another just nice example. It's funny, I got it the next week of massive histoplasmomas. I showed them with the nice sort of benign. This one has more chunky calcification, but the reason I have, and there's another one here, but if you go back to the radiograph, you can actually see there's a bunch of splenic calcifications because David always queries me on that, and this one you can bet is histo. So just quickly that. Now this is kind of cool. Speaking of histo, so this is a 56-year-old female. Has psoriasis or psoriatic arthritis and is on Humira, and at the time presented with a cough and fever, and you can see there's consolidation in the left lower lobe, nice little spine sign there. Looks like run-of-the-mill community-acquired bacterial infection. It was treated with whatever the drug of choice is at the time, Z-Pak or something, but did not get better, and so they did some more imaging. Let's see, and so this was I believe the next CT done. You can see it has a history of smoking, some emphysema, and then we have this rather large area of consolidation with some peripheral ground glass opacity down in that left lower lobe. So you'd still think about a bacterial infection. I don't think there was a tiny sliver of an effusion, and really some reactive lymph nodes in the draining pathway. So all looks like a typical bacterial infection, but wasn't responding. So they did a further workup, and lo and behold, they found granulomatous inflammation. So around here I think about blasto, but no, this isn't blasto. This ended up being histoplasmosis, and this is the only case of histoplasmosis I think I've ever seen, at least documented, that presented as consolidation. It's a really rare finding. It's almost always a nodule or a cluster of nodules or just lymphadenopathy. And then I've got some serial imaging. So this was a month later. You can see the ground glass sort of went away and it retracted a little bit. Nice air bronchograms, but still looks like your run-of-the-mill community-acquired bacterial infection. Then this is the patient about 4 months after the initial diagnosis, and it's going away, but you can see some dilated, distorted airways. And then this is the most recent CT here back in October, and you can see there's some residual bronchiectasis. So a rare manifestation of acute histoplasmosis. I'm guessing the impaired T cell immunity from the Humira probably played a role in it. I think that's a TNF alpha inhibitor. So, and I don't know if it's a new infection or a reactivation of an old infection, but just very unusual.
Very unusual. Wow.
Jeff, do you think it's because he couldn't form granulomas? There's no nodules or?
Yeah, maybe. Maybe.
Because is there anything, did the mediastinal lymph nodes resolve, and the spleen was okay also, right, on this one?
Yeah, as far as I know, let's see. You can see the lymphadenopathy got better, and I have a non-com, but the spleen wasn't big. I mean, presumably it was systemic, but it's not billed as a disseminated histo. So, but they're just treating with itraconazole and it's getting better, but it's going to leave some scar in there, which, we typically don't think of histo doing other than a little nodule just to saying it was there. All right. This is kind of a fun case. I was reading a follow-up today and I stumbled across this comparison, and I see this dialysis catheter kind of going into the lung. I was like, uh-oh, that doesn't look good. And you can see this was a trauma patient, had plated at some point. And this is a nice companion to a case Howard showed not that long ago. So, we always see line misadventures, but this one, you don't see a big hemothorax, you don't see a pneumothorax. It looks pretty clean, but I'd still be worried about it. So they did a CT scan for this, and there's the line, this hemodialysis catheter, and you can follow it into the superior vena cava. There's azygos coming in, and then you'll see it just keeps going. But it seems to be in a channel. There's this little soft tissue structure that has a branch coming off. So it just keeps on going out into the lung. And if you go to the lung windows, you see there's really no tract around it, nothing that looks like a tract, like you'd see with a projectile. There's no pneumothorax from this. So if you look carefully, you can see that these vessels come right up here and seem to connect to the superior vena cava. So it looks like anomalous venous drainage. And I found an old trauma scan from many, many years ago. They're thick cuts, but you can actually see this right there. There's the anomalous pulmonary venous drainage, draining that middle lobe and part of the lower lobe there. So this is anomalous pulmonary venous drainage, and the catheter took a nice course right through that. Now, granted, that's probably bigger than the peripheral vein, but it somehow managed to accommodate it. They were able to remove this without incident, but not one you expect to see very often. I think we've seen, I think it was Howard showed one in the left upper lobe that went out this way.
No, I showed one like that, but the catheter much more obviously went into the right upper lobe, straight across, not like this one's going. This one's scary.
Yeah, this one looks like it. Yeah, this one you almost wonder, like, it didn't cause any problems. So that was kind of a fun case. Let's see. This is a crazy case. And some of you, I sent some of the earlier pictures, but I got the post-op pictures. So this is a young guy, he's like 47, and has a history of a tracheal squamous cell cancer. And he was treated with chemoradiation. He wasn't a surgical candidate. And he was transferred to us urgently because he was having hemoptysis. And you can see there's this little tract of contrast coming off his aorta and going right up to this tracheal margin right there. And there's all this soft tissue around it. So presumably this is a fistula right there, you wonder. And I mean, usually these are fatal, either from massive bleeding or air embolism. But he managed to, and you can see he's got a little diverticulum where his bronchial artery comes off there. But he was emergently operated on, and they did a pretty complex repair. So they were able to, they did a hemiarch type repair. So they resected the fistula, they brought up omentum, and what was the other tissue they brought up? Oh, and they took pericardium to cover all this, and then they rebuilt the aorta here. So you can see there's sort of where they patched it there, and he is luckily doing very well at this point. I think he's still, but yeah, and they've got a, let's see, that's just a big drain coming up in there. But yeah, I mean, you rarely see these because they're usually fatal.
Yeah, yeah.
But yeah, so this one they brought up, so it was omentum and pericardium to cover that defect. So hopefully that will help. But that, we've seen tracheoesophageal fistulas, but again, aorto-tracheal fistula is very rare because usually patients die rather quickly. So
some of the tissue around it initially is presumably scarred mediastinal fat from the fibrosis. There's fibrous tissue in there.
Yeah.
From radiation. Excuse me.
That one. I'll do this one real quickly. This is kind of a cool case. So this patient is about, if I remember, I want to say about 2 weeks out, maybe a little less, from a lung transplant, double lung transplant, has a history of scleroderma. And, we see these post-op radiographs and always looking for air leaks and reperfusion injury, but you'll notice this upper abdomen looks kind of funny here, kind of curvilinear lucencies. So patient was noted to have some pneumatosis. Here's an abdominal radiograph. It shows a lot more extensive, predominantly in the colon here. They ended up, here's just another one down here. You can see even more pneumatosis. So it got worse, and the patient was developing some pain. I think there was a preoperative abdominal CT that showed maybe some extraluminal gas or a small amount of extraluminal gas. So he ended up getting exploratory surgery and found just pneumatosis, no ischemic bowel or anything. So they didn't resect anything. And then this is a recent CT. And you can see just there's contrast in, but you can see all of this large bowel pneumatosis, which is unusual to be sort of a benign thing, but it does happen. I think I've seen this now one other time in a lung transplant, but I can't remember if that was a scleroderma patient. Of course, they can get bowel problems with fibrosis in the bowel wall, so unclear exactly why this happened. But given they had symptoms, I think the surgeons made the decision to take a look and make sure, because we have seen lung transplant patients have ischemic problems for various reasons. So interesting case. And from a radiographic standpoint, as Travis always said, the lungs are probably the least important thing on some of these post-op radiographs, and really looking in the corners for the things that we don't always see. And just real quickly, I'll go ahead and show this last one before I forget about it. So this is my fellow sent me this case, Melissa. This is a patient who is a kidney pancreas transplant who had developed some abdominal masses. Let's see if I can find a couple of them. I think I grabbed the right CT. I hope I grabbed the right CT. Anyway, did develop some abdominal masses, and there was concern about PTLD, and you can see these nice lung nodules here. You know, we think about fungus, nocardia, metastases if there was a malignancy. They're pretty well defined, but they're kind of smooth looking, typical lymphoid type nodules. Anyway, they confirmed this to be PTLD, and it's Epstein-Barr virus positive type of PTLD. So it can present as nodules. I know we've seen a lot of cases. I haven't seen one in a long time, so it was nice to see one with lungs. I thought I grabbed the right, I think this is the right abdominal CT I must be going to. Oh, there's a big mass right here. And a couple other ones too. So it can be just in the lungs, and sometimes it's elsewhere. So, and it's usually EBV positive. So this is a proven case of EBV positive PTLD. And I included the radiographs in there. The nodules are kind of hard to see, but they're there. All right. It's the top of the hour. So thank you, everybody. And I'll talk to you next week.
Thank you.
Thanks,
Thank you.
everyone.
All right.
Thanks, everyone.
Bye, everyone.
Bye-bye.